Well, thank you. First of all, thank you everybody for coming. I'm Michael Morwood. Just came to the area, which is great. I'm meeting everybody both down in Portsmouth and then up here as well. Goal of today really is to get a little bit of information out there about hip and knee pain, hip and knee treatments, where I'm coming from as an orthopedic surgeon, what we can do to improve, quality of life. That's, in the end of the day, that's kind of what the business we're in, is trying to improve quality of life. So I'll go over a bunch of different things, from some basics to a little bit more on hip and knee replacement, and also non-operative treatment options. So jumping right in. So osteoarthritis, that's kind of going to be the #1 thing we talk about today. That really is a big problem. So we're talking more than 40 million folks in this country have some sort of arthritis or arthritic complaints. Obviously, I specialize in hips and knees, but all of the joints can be affected. So it's the major joints first: hips, knees, shoulders, ankles, and then some of the smaller joints, fingers can get involved, toes can get involved, elbows, all those sort of things. So everything is affected. Now, what is a joint? In a basic sense of it all, I like to use the analogy of a tire. So here the bone is going to be the wheel, and the tire, or the tread, is the cartilage. So if you think of it like that, it's just basically where two bones are coming together. There's a very, very slick surface, this cartilage surface that sits there between the bones and allows them to glide normally across one another without having a problem. So if you go back to this analogy of the tread or the tires, you can think of it as basically it's tread wear. So the wheel underneath is hopefully okay, but that whole cartilage cap, or that tire tread, has been worn away. If you look at it in sort of a cartoon model, you can see that there. Here's a normal appearing kind of cartilaginous surface. And then we start seeing this breakdown, this decay of cartilage. The menisci get torn, bone spurs occur. And these are the sort of things that folks have on the x-ray, which cause so many problems, so much pain. Now, what's the cause? So primarily, osteoarthritis is the most common arthritic form that I was saying before. It can be a result of aging, but it's not 100% the cause. We do know it's multifactorial. Genetics play into it. Inflammatory markers, we've been testing certain inflammatory markers. We know folks who have osteoarthritis, or this wear and tear arthritis, their knee joints or their hip joints or whatever will have increased levels of inflammatory markers. So it's not just aging that causes it. It's kind of a one-to-one. They go hand in hand, but it's not 100% the cause. As the joint itself gets a little bit older, the ligaments supporting the joint weaken. You have a little bit more instability, and when instability occurs, you can imagine if your knee joint should be like this, but now it's kind of rocking back and forth, it's going to cause a little bit more damage to the surrounding tissues and structures. So like I said, there are other causes of arthritis, not just the wear and tear kind. Sometimes on my other half of my specialty, so trauma, I see this all the time. If you have a break in the bone that goes into the joint, if you have a break of the tibia bone or the shin bone that goes into the knee, if you have a femoral neck fracture or a hip fracture, we know those are high likelihood chances of actually occurring and increasing your chances of arthritic conditions in the joint. One point we always want to get out there is the effect of weight loss. So we know from studies, each pound of weight loss is a 7-pound reduction of forces across the knee joint. So if you lose 10 pounds, even 10 pounds, that's a 70-pound reduction that the knee joint is seeing, and it likes that a lot. So we definitely know less weight, less load on the knee. Common misconception, a common misnomer are the two words osteoarthritis and osteoporosis. So those are not the same thing. Osteoarthritis, like we've been talking about, is wear and tear, degeneration of the joint itself. Osteoporosis is actually just a thinning of the bones. So in osteoporosis, the bone structure is actually normal. There's just less of it. Osteoarthritis is a wear and tear degeneration of the joint itself. So here's a little scanning electron micrograph of what a normal bone structure should appear like. There's small little holes called trabeculae. That's where the blood vessels and the nerves and things that are in bone actually course through. And then on the right side there, you see osteoporotic bone. So it's actually normal bone. There's just less of it. So different than osteoarthritis. Well, how do you know that you have arthritis? So there are some very kind of tried and true symptoms of arthritis. So pain is the #1 thing. Pain when you've been sitting for a long period of time listening to me. I see that. Pain when you've been walking up and down stairs, pain when you get up first step in the morning. That's usually the number one symptom, pain. So what do we see when we take x-rays? Well, this is a great example. So this is a healthy appearing knee on the outside there. The space between the bones, you can't see cartilage on an x-ray, but you know it's there because there's space between the bones. So this right here is where the cartilage lives, the space there. The joint surfaces all look very uniform and healthy. There's no bone spurring or whatnot. If you go over to this osteoarthritic knee, that's just bone grinding on bone. That's the number one thing right there. You see all this hazy white stuff, big bone spurs all around, bald tire. There comes that analogy again. There's no tread left. Those wheels are just rubbing on the wheels. And I guess actually another analogy I'm just thinking about right now, you ever see one of those car chases when somebody's tire blows and the wheels are running on the ground, it's just sending up sparks? That's kind of what's going on. The tire is gone and the wheels are just grinding on each other. Same thing if we look at a hip. So this is a hip's a ball and a socket. See nice healthy cartilage there between those two bone spaces. Over here, tread's gone. Bone on bone arthritis. Incredibly painful. One of the actually most common things people ask is, what is a bone spur? So a bone spur is actually your body's attempt to limit motion. So if you think about how painful it is when your joints are arthritic and they're rocking against each other, your body actually produces some bone to try to shut that motion down and limit it because it doesn't want that pain, that inflammatory reaction to occur. And you know, if we don't typically see it as much in this country anymore, but if you let this go on long enough, the joint actually fuses together. So what are the goals of treatment? One of the big things I want to get out there today, goals of treatment, especially from an orthopedic surgeon standpoint, is make your life better. This is a quality of life problem. We know it has significant effects on folks, playing with their kids and grandkids, going to the store, hanging out at the house, doing your things around the house that you like to do, gardening, walking, swimming, all this kind of thing. So our goal is to make your life better by relieving pain, increasing the motion, and improving strength. My kind of approach to treatment for all sorts of pains, but arthritic type pain, especially in the hip and knee, is a ladder approach. I like this analogy very much. We always start at the bottom, non-operative treatment first. We do everything we can before going to surgery. First rung of the ladder, our mainstay, our number one gun is going to be medications. So again, the pain from arthritis is an inflammatory response. So again, take the knee. If the knee gets angry and inflamed, it swells. The capsule swells. The capsule hurts when it swells. We want to limit inflammation. So medicines like ibuprofen, Advil, Aleve, Celebrex, meloxicam, these are all medicines. They don't cure anything. They don't treat the underlying disease, but what they do is they limit that inflammation, limit the inflammatory response, and hopefully make your pain feel better. Earlier on arthritis, these medicines can be life changers. They can help you out a lot. But again, we do know the natural history of arthritis is it tends to ebb and flow. It gets a little better, a little worse, a little better. But it does have a kind of a slow decline as the cartilage continues to wear, the soft tissues continue to weaken and such. But these medicines can be very good, especially in the beginning. Next rung of the ladder, injections. I don't know if anybody here has had a cortisone injection before, either into a joint or into soft tissue. And again, these aren't the most pleasant things in the world, but they can provide you with some significant relief. Cortisone is probably the biggest one we use. This is just a steroid. It's a generic term for steroid. And essentially is basically taking a whole bunch of ibuprofen, crushing it up, and putting it directly into the joint that's affected. So it's like taking the medicine by mouth, but hopefully with fewer systemic effects. We do know some of those other medicines can have effects on your kidneys, on your stomach, on your liver. So if you're not a candidate for those medicines, this can certainly be a next good step. There's another kind of branch of injections. These are visco supplementations. So folks might have heard of rooster shots. They're this is made of rooster comb or whatnot, but they're basically lubrication injections. They're made of either Hyaluronic or glucosamine, and they're supposed to go in and lubricate the joint. The data out there is a little soft in terms of how much they actually affect things. They're, at their best, they're equivalent to cortisone or steroids. But again, they're non-operative, they're non-invasive, and they're relatively easy to do. So if it's one thing in terms of our ladder approach, it certainly can be useful. Now, joint protection. So daily exercise can actually be quite helpful. Stretching, preventing those contractures, and getting the muscles around the joints nice and strong is the best thing to protect them. So for the knee, quadriceps. Having your quadriceps muscles working effectively making sure your knee is going in a front to back motion rather than having instability side to side. It can be very beneficial. Hip muscle can be incredibly helpful. So getting the big muscles on the outside of the hip, that's the number one determinant of how much force your hip joint is seeing, is this big muscle called your abductor on the outside. So gluteus medius is the actual technical term for it. But getting those muscles nice and strong can be incredibly helpful. Can be both helpful before an operation and after an operation to protect the joint. Braces. Braces are asked about quite often. They do work with a couple of caveats. There's a whole bunch of different braces. There's braces that you can buy off the shelf, and there's $2,500 braces that you can order custom made. I don't typically prefer the $2,500 ones because I think that they're too expensive, and the other ones typically seem to work. The reason they work is for a couple of different reasons. Number one, they can help prevent a little bit of the swelling. So again, take the knee, reducing the swelling and the inflammation in the knee joint, even with just a little bit of an external compression sleeve, can be very helpful, can reduce the pain. They also help with some balance and what's called proprioception. So proprioception is your body's ability to know where you are in space without seeing it. So if I put my hand up and close my eyes, I know where it is without seeing it because of this proprioceptive feedback. Joints work heavily on proprioception. The ankle is a great example. So ankle proprioception helps you when on uneven ground, so it prevents kind of these side-to-side instability moments. So this is one of the things that the brace can actually give your body a little bit of feedback to tell it where it is in space, prevents a little bit of instability, and can help with some of the pain. External support aids, so we've got a cane, we've got a walker, we've got crutches. Again, that just unloads the joint. It actually takes the moment arm, to come back to a little bit of the physics, takes the moment arm of the joint farther away, which lowers the amount of stress that the joint is seeing. So they can be pretty helpful. So a cane in the opposite hand, a walker, or even crutches can sometimes be helpful. But by the time we get to something like that, we're usually wanting to talk about the next step. So obviously, when all else fails to improve the pain, we talk about that top of the ladder approach. This is when the surgery is involved. It's a little bit more involved than opening the hood here. As you can see, this person's getting the hood open there. I wish it was that easy, to be honest with you, but it's not. But here, if we're going to talk about surgery, we need to talk about what do we ask? It should be a conversation with your doctor. The number one thing for both of these, for hip, knee, shoulder, or whatever, is a quality of life improvement. We want you to get back out doing the activities that you enjoy doing. We want to get back out to doing fun things with your family and all of that. But these are all questions that should be asked. This is what the actual implants themselves look like, which brings up another great point. So a lot of times people say, what is a knee replacement? All right? Do you go in, do you take my knee out, you throw it in the trash, and you put a new knee in? It's not at all like that. It's actually just, again, you go back to that tire analogy, it's a resurfacing, a retreading. So we make an incision, we go in, we actually make very precise cuts, fine cuts, removing that diseased cartilage, removing that exposed bone, removing the soft tissue that's getting inflamed and irritated, and then it's just putting a cap on the femur bone and a cap on the tibia bone. Just like a dentist puts in a crown. Really, literally, it's just a cap on the end, piece of plastic in between the two so that they can articulate and move smoothly. Same thing here with the hip. The socket gets resurfaced, the head gets replaced, and there's a little piece of plastic there that it rotates on, and there you have it. One quick thing we want to talk about is consumer beware. So there's a lot of press, there's a lot of advertising, there's a lot of information out there that can be used both as a benefit and a little bit of a negative as well. Basically what this slide is talking about is it was a poll of 700 plus surgeons, so folks who do hip and knee replacement essentially. And they said, what are your experiences with people coming to your office talking about things they've seen in the newspaper, things they might have heard about on the radio, and some of the problems or the negative impacts of that were that the patients weren't necessarily better informed. They may have had some misinformation. They may have been less open to alternatives. So as a surgeon, it's my job to do the best, safest operation that will give you the maximum benefit, the maximum opportunity to get back to where you need to be. Sometimes that means an anterior approach hip. I like the anterior approach hip. I do the anterior approach hip. Sometimes it means a lateral approach to the hip or a posterior approach to the hip. I mean, these are all conversations that should just be had, and we want to make sure that everybody is getting the correct information. And that's, again, comes back to the question before of we just have the conversation. And in the end, it's the best operation for you with the safest operation with the fewest amount of complications. So to conclude here, we want to talk, again, the latter approach to arthritic pain, for me, for the hip and knee, but for every joint, really. It's the non-operative stuff first. You want to try medicines. You want to try physical therapy. You want to try injections. But when it comes to the point of it's affecting your activities of daily life, it's affecting what you want to do for fun, it's not letting you do things like get down to the York Beach on a beautiful day, that sort of thing. We talk about surgery as being a very beneficial, safe operation or a safe component of the overall care. Not too old for total knee, total hip. I mean, this has been one of these misnomers that we hear all the time. Is, am I too old? You know, can I not do this? I'm trying to push that, especially with the primary care physicians even, because there is still a little bit of misinformation out there. The new technologies that have come in are certainly beneficial, but beware, have that conversation. The surgeries themselves are getting better and better, safer and safer. The approaches are a little bit better. Implants are a little bit better. And then the whole perioperative course is better. Nowadays, with the medicines that we use, with the numbing medicines that we use in and around the joints, with the early, getting up with physical therapy, with the anesthetics that we're not putting anybody to sleep anymore, and we're doing this as an outpatient now. Things that used to take, a week in the hospital, sometimes you can get done at 8 o'clock in the morning and you're at home by 5 o'clock. Again, not for everybody, but we see the transition away from the worst of the worst to, a one-night hospital stay, even a two-night hospital stay can be very, very beneficial. So as a surgeon, I love to operate, of course, but we never want to push operations, but what it is our job is to get the information out there. What are the alternatives? What are the therapies? What does the actual operation itself look like, feel like? What is the perioperative time? And as long as everybody has the conversation.